to Dr. Lalit Bitla and all the chairman and the moderator for giving me this chance. First question I like to ask Prashant Bhavankule is, do you differentiate between OCT and OCTA or both are same?
OCT is an integral part of OCTA, sir.
No, so you don't, so you say ki OCT and OCTA are different or the same? I want to know, can you get away with the OCT? Or
No.
you see morphological picture or you see only Octa pictures?
Sir, OCT is an inbuilt system, or it is a second platform. OCT comes as a primary platform and then comes the Octa.
So,
Once you have an Octa, everyone has an OCT.
Let me interfere in between. No cross questioning. You try to defend. That's all.
But Lalit, you already told Avindra may back out, yeah?
No, let him defend. No? That's the challenge.
Okay.
Let's hear. Very interesting.
Prashant Bhavankule is a star of Vidarbha and Maharashtra, and he loves to play in 8 figures. He has a Ferrari. He owns a 3D imaging system, big buildings, and another 8 figures machine, that is OCTA. So costly instrument, you need a talent management company like Quan. And these two things add to the cost burden, who is already loaded with OCT, FA, and anti-VEGF. And now you are putting one more investigation in, which you will charge, that is Octa. AMD is basically classified into 3 types. Type 1, occult CNV below RP. These lesions are basically PCV lesions. Type 2 lesions are classic CNVMs above RP in subretinal space. Type 3 lesions are intraretinal CNVMs that we call as in RAP lesions. And now we'll start with this study. Shankar Netralaya Vitreoretinal Study Group said 49.7% of Indian patients presenting with clinical feature of neovascular AMD harbor PCV. So almost half of the patient of AMD, wet AMD, are polypoidal choroidal vasculopathy. Now we see an example here. You can see a double hump PED with fluid and exudative AMD. And if we do an ICG, you can see nice polyps here. And on giving injection, this polyps has regressed. There is an inactivation of polyps and this is regressed. But the moment we go on to OCTA pictures, we are not able to see any polyp in this OCTA picture. What is wrong? We cannot diagnose polypoidal choroidal vasculopathy with OCTA. This is another patient. You can see a PED here, 2 small polyps. And on OCTA, we cannot see any polyp here in OCTA. So to conclude, OCTA is not useful in diagnosing cases of PCV. Why we are not able to diagnose PCV on OCTA? Because there is a minimal blood flow. Until unless you have a blood flow or there is a blood flow in the vessel, you cannot diagnose a lesion. So PCV lesions, you cannot diagnose on Octa. So you need a multimodal imaging like OCT, FA, ICG is key in diagnosing PCV. So half of the lesions you have missed on Octa. Now this is another patient you can see here. You can see a yellowish discoloration to temporal to the fovea. And we did an OCT in this patient. You can see intraretinal fluid, gave anti-VEGF, rebounded back again. There was multiple recurrences and we gave somewhere around 8 to 9 injections. And then I said something is wrong in this patient, did an FA in this patient. You can see leak temporal to the fovea. And on Octa, if you see the superficial layer, there's no lesion here. Deep retina, there's no lesion. On outer retina, you can't see anything. And in choroid picture, you can't see anything. So we got this machine. I tried to diagnose this disease on Octa. I was not getting any kind of information on Octa. Subsequently, I kept on injecting on this patient, and you can see on OCT, there is an PED which has developed, and there are intraretinal lesions here. And you can see this V-shaped, and at this stage I realized that this is a RAP lesion, and this is an intraretinal CNVM which is pulling the retinal pigment epithelium, causing NCNV. Then I did an ICG, and in ICG what you can see here, there is a small hotspot which shows an active CNVM within PED. So on OCTA, we were not able to diagnose the disease. Only on multimodal imaging, that is OCT, ICG, and FA, we were able to make a diagnosis of RAP lesion, which accounts for 4.8% of all wet AMD cases. RAP lesions are difficult to diagnose on OCTA. So 55% of all wet AMD cases cannot be diagnosed on OCTA. This is how the RAP lesion develops, and I showed you serial OCT where we made a diagnosis on morphological picture of OCT. Now, what you can diagnose on OCTA are classic lesions. Like this patient, you can see a CFAN appearance of an CNVM, and on morphological feature, you can see a thickening and fluid. I injected this patient, and you can see the fluid has disappeared. But my problem is the loops of the neovascular membrane stays or are visible on OCTA. Now, should I proceed with an VEGF injection, or I should wait for the fluid to reappear? Meaning, so my next question to Prashant Bhavankule is, will you treat CNVM on morphological picture of OCT or membrane seen on OCTA? I will not treat on OCTA. I'll treat on the morphological picture of OCT. Whenever the fluid comes, I'll treat on OCTA. So to conclude, it's an expensive tool, will add to the pre-existing financial burden. 55% of wet AMD cases cannot be diagnosed by OCTA. Multimodal imaging, key to the diagnosis and treatment. Treatment is decided by the morphological pictures of OCT and not on OCTA diagnosis of vessels. Thank you very much.
Thank you, AG, for